Assalamualaikum.
Waalaikumsalam.
Waalaikumsalam.
In last class we done about SSRI, SNRI, and these three groups we done. Yeah. Now the group number 4, monoamine oxidase inhibitor, enzyme category, monoamine oxidase inhibitor. In this group, the drug name
Terkeluar ya?
Mawai.
Aku kira aku yang terkeluar.
Hujan deras dia.
Hujan
deras di tempat ini Pak.
Kalau aku yang terkeluar kayaknya menimbulkan gosip. Iya.
Yul sampai ngeteh tuh. Dingin gak Yul?
Mana kalau Yul?
Gila sih Yul, gaya banget dah.
Wait, be back soon.
Mana kalau Yul?
Be right back.
Wih, satu muka, 4 tangan. Gila.
Charging.
Apa nih, Dokter Paul bagaimana? Beneran badai?
Laptopnya belum dicas, belum full.
Terus nyalakan suara.
Ya. Jangan tahu bicara sembarang. Si Wendy wartawan, udah kasih viral loh.
Sorry sir, I no voice.
phenylcypromine, phenelzine, iso, carboxide, iso, carboxylate. So these are main 3 monoamine oxidase inhibitor. So one thing keep in mind, these 3 inhibitor, if you give in high dose, like if you increase the dose, then they become non-selective. What does mean non-selective? Non-selective mean they also block enzyme B. Okay, they also block enzyme B. So if we use proper dose, so they just go for enzyme A. They just go for enzyme A. Phenylcypromine, phenelzine, iso, carboxide. So these drugs also be used for depression. Okay, they also used for depression. And some important thing about this group: never combine with SSRI, SNRI, and TCA. Must keep in mind, these drugs we can use as a single therapy, monotherapy, never combined with SSRI, SNRI, and TCA. Okay, so these drugs must be as single therapy. So if you firstly you wanna use monoamine oxidase inhibitor, and the patient, for example, you start first therapy. So first you use monoamine oxidase inhibitor. Okay, the patient still not feeling well. Patient not no response. If patient not response, then you want to shift patient to another drug because patient not give good response. The patient still have the disease. The patient not give good response. Now you want to shift. You want to shift to shift patient on SSRI, shift patient on SNRI. So for that purpose, if you want to shift, you must wait 2 weeks. Okay, you must wait 2 weeks. Wait 2 weeks, then use SSRI. If you not do this, what happen inside the patient? Inside the patient, monoamine oxidase inhibitor inside the patient, what they're doing? They're causing very severe serotonin syndrome. Okay, they're causing very severe serotonin syndrome. Very dangerous. Okay, maybe lethal for patient. Monoamine oxidase inhibitor. If you want to shift on other, for the first thing, we never combine. We use as single therapy. We not combine with SSRI and SNRI and TCA. Okay, understand? We not combine with SSRI, SNRI, and TCA. So if you want to use, like if patient not give response, you want to shift patient to SSRI, SNRI, then you must wait for 2 weeks. Okay. While these 2 weeks, another thing, food interaction. If you remember Parkinson disease, the food interaction, fermented food, you remember? Fermented food. Fermented food like pickle, like cheese, like alcohol, especially grape wine. Grape wine, okay? These food are the fermented food containing what? Pyramine, okay? All fermented food, they contain pyramine. This pyramine doing what? Pyramine is causing what? Reuptake inhibitor of norepinephrine, okay? So this tyramine in fermented food, this tyramine breakdown done by monoamine oxidase enzyme. Breakdown done by this monoamine oxidase enzyme break this tyramine, okay? So if you're using inhibitor of this, so then what happen? If you eat this, tyramine will be very high. Understand? So this tyramine causing norepinephrine very high. Now this patient have issue hypertensive crisis. Hypertensive crisis, okay? Hypertensive crisis. So if you're using monoamine oxidase inhibitor in any person, must avoid fermented food. Must avoid avoid this fermented food. Understand? Pickle, cheese, alcohol, grape wine. So they can increase norepinephrine inside the body very high level, very high level. Okay. So why? Because just because of this tyramine. Understand? So it's a food interaction with monoamine oxidase inhibitor. Food interaction. What are the uses of these monoamine oxidase inhibitor? Monoamine oxidase inhibitor here we're using for typical depression, depression. We also use for Parkinson disease. This you know already, okay? Parkinson disease. What is Parkinson disease? Monoamine oxidase B inhibitor, okay? Not A. B inhibitor for Parkinson disease. If you want to use A inhibitor, monoamine oxidase inhibitor enzyme A, then you give dose a bit high, dose more. Okay, high dose. In high dose, they also can block B also. Understand? So it's all about monoamine oxidase inhibitor. Monoamine oxidase inhibitor used as single therapy. Single therapy for depression. Understand? Not combined with any drug. So if you combine with other drug like SSRI and SNRI, so it's not good for patient. SSRI and SNRI and TCA not combined with these three groups. Okay. So what happen inside the patient if you combine serotonin no more breakdown, it lead to serotonin syndrome. So it is a very bigger side effect. Okay, serotonin syndrome. Understand? Monoamine oxidase inhibitor is causing hypertensive crisis. This is the important thing here. Hypertensive is the main side effect of these drugs. And these monoamine oxidase inhibitor also have interaction with fermented food. Must keep in mind, okay? Have interaction with fermented food. It's all about main therapy for depression. Now we talk about some other drugs for depression. Other drugs. These are atypical antidepressants. Atypical antidepressant. These atypical antidepressant have no group. Okay, like just be done grouping like SSRI. They not belong to SSRI. They not belong to SNRI. They not belong to TCA. They not belong to monomer oxidase inhibitor. So they are something different. Their nature totally different. Okay, but they work for depression. The first drug, bupropion. Bupropion. The one drug you remember, buspirone in benzodiazepine family. Atypical anxiolytic, non-benzodiazepine is zolpidem, zolpidem, and buspirone. So buspirone, not mixed with that, okay? Buspirone. It's a bupropion. Bupropion, it inhibits the reuptake inhibitor for norepinephrine and reuptake inhibitor for dopamine also. Reuptake inhibitor for norepinephrine and dopamine. Reuptake inhibitor. Reuptake inhibitor. This drug, this drug is very effective in the. It's also very important MCQ. Very effective in if patient want quit smoking, smoking cessation. For smoking cessation, very effective use. Can be used for depression. Okay. How we use for depression? Because they increase norepinephrine. Yeah. If other drugs like SSRI, SNRI, TCA, monoamine oxidase inhibitor still not effective for patient, we can go for atypical antidepressant like bupropion. Okay, bupropion is also used for depression. The important use must keep in mind for smoking cessation. If someone want to quit smoking, we can use bupropion in that patient. Okay, because the patient when want to quit smoking have craving for smoke, must have nicotine by the body. Okay, to quit smoke, we can use this. Another drug, if you remember in cholinergic system, ganglionic blocker, methylamine, also for smoking cessation. Okay, methylamine, ganglionic blocker, methylamine. Okay, Okay, second drug, mirtazapine. It also belongs to adrenergic system. Mirtazapine, if you remember alpha 2 agonist. This alpha 2 agonist. Clonidine is agonist. Mirtazapine. This mirtazapine alpha 2 agonist. This mirtazapine alpha 2 agonist. What is the function of mirtazapine? Alpha 2 receptor here. Increase release of norepinephrine. Yeah? Increase release of norepinephrine. What's the problem in depression? Problem in depression. In depression, what inside the brain? Little norepinephrine. Yeah. So mirtazapine doing what? Increase release of norepinephrine. So this mirtazapine we also can use for depression. Understand? This mirtazapine also can use for depression. Another benefit, this mirtazapine increasing weight gain. Increase the weight gain, one thing. Another, increase appetite. It's also appetite stimulant, increase appetite. So the person, depressed person, if very thin, depressed person not taking food and having weight loss and these things. Depressed person just sadly, lonely, sit alone, not eating, nothing, everything, all the lifestyle change. The depressed person thin, also depression. So it's very good drug. Because person very thin, yeah, weight loss, having weight loss. So this drug doing what? Weight gain. Also increase appetite. Yeah. So this drug is very good in the person having low weight. Mirtazapine for depression in thin person. Okay. For depression in thin person, for underweight. If the person weight is very low and having depression, we can use mirtazapine. Mirtazapine treat depression. Mirtazapine increase appetite. Mirtazapine increase weight. Two extra benefit. Understand? So about mirtazapine. Okay, next one. Nifazodone. Nifazo. Nifazodone. Trazodone. Nifazodone. Trazodone. Vilazodone. Zodone. These are nearly same group, okay? Same name. But they not have proper grouping. Nifazodone, trazodone. So these drugs, Nifazo, trazo, going for 5-HT2 receptor. These drugs go for alpha 2 receptor. These drugs go for histamine 1 receptor. So they having here you can see reuptake and also go for blocking this receptor 5-HT. 5-HT2 receptor. Okay, so no more negative feedback system. No more negative feedback system. So you can increase serotonin, yeah. So no more negative feedback system for norepinephrine. You can increase norepinephrine. You can increase serotonin easily. So these drugs. So you can see this group. This group is totally different from SSRI. How? SNRI. How they working? They are reuptake inhibitor, yeah. Tricyclic antidepressant. So they are reuptake inhibitor. Understand? They just block the reuptake. So here, the phazodone, trazodone, vilazodone, what they're doing? The presynaptic membrane here, the presynaptic membrane here having alpha 2 receptor, presynaptic membrane here having 5-HT2 receptor, 5-HT2 receptor. So this 5-HT2 receptor giving negative signal inside, giving negative signal inside to decrease the release. Yeah. So if you block this receptor, these two, nifazodone, trazodone, they're doing this. They block these two receptors. So when they block this receptor, norepinephrine release more and 5-HT release more. Okay, so this is how they're working. Understand? This is how they're working. So what the side effect of these drugs? The side effect, they're also going far. So they're increasing this one. So they also go for alpha 1. They also go for alpha 1, alpha 2 and alpha 1. So hypotension is the problem with these drugs, postural hypotension. They go for H1 sedation. They go for H1. One side effect, hypotension. Second side effect, sedation. Second side effect, sedation. In male, very dangerous side effect, priapism. Priapism is a painful erection. Priapism in male only. Okay, very painful. Priapism, hypotension, sedation. Okay, these are main side effects. Nafazodone, trazodone. So why we not using these drugs? These drugs, if you want to use for depression, we can use for depression. But we need to use for depression in high dose as compared to other depressant. High dose. We must give very high dose as compared to SSRI, as compared to SNRI, if you want to treat depression. So in male, these drugs must avoid in male patients because it's dangerous side effect priapism. It can lead to later infertility. Okay, hypotension, sedation. These are not much dangerous side effects. Priapism is a bit like dangerous side effect in male. Okay, a problem with like sexual dysfunction. Understand this is all about depression. All drugs done. SSRI. Now we summarize SNRI, tricyclic antidepressant, monoamine oxidase inhibitor enzyme A, and last group was atypical antidepressant. Okay. SSRI, if you remember, SSRI, fluoxetine, deroxetine, fluoxetine, okay, fluoxetine, fluoxetine, paroxetine, citalopram, sertraline, okay. SNRI, venlafaxine, venlafaxine, and duloxetine, TCA, imipramine, amitriptyline, monoamine oxidase. This we just now finished. The name you can revise from previous, okay, from previous lecture. I already explained. Don't have to waste time on this naming. So, what is your first preference for depression? SSRI. So what are the side effects of SSRI? Serotonin syndrome, very big problem, yeah. Serotonin, serotonin syndrome is the main issue with these drugs. Okay. SSRI is our first line. How about the SNRI? SNRI also extra use for SNRI, neuropathic pain, neuropathic pain. TCA, TCA, lot of side effects. TCA go for alpha receptor, TCA go for M receptor, TCA go for H receptor. Okay, lot of side effects. So TCA producing lot of side effects. So TCA have limited use, just used for neuropathic pain. Okay, TCA we use for in bedwetting children to control at night, nocturnal at night, nocturnal and nocturnal and bedwetting in children, imipramine. Okay, so TCA, because big list of side effects there, so that's why limited use for depression, limited use for depression. Okay, so preferable drug SNRI, SSRI. Another option, monoamine oxidase inhibitor, transcypromine, phenelzine, and isocarboxylide. And these drugs we can use for depression also, but take care about fermented food to avoid hypertensive crisis. Okay, and not combine these drugs with SSRI, SNRI, and TCA because it can lead to serotonin, dangerous serotonin syndrome. Okay, understand? So if you want to quit monominoxidil inhibitor, then wait for 2 weeks. Wait for 2 weeks to shift patient on another drug. Also, there must be dietary restriction. Okay, you must advise patient and also not using fermented food. Understand? A typical antidepressant for quit smoking must keep in mind important question. Okay, bupropion for quit smoking or use for quit smoking, mirtazapine. This action for reuptake inhibitor for norepinephrine and dopamine. Mirtazapine is a cholinergic drug. Sorry, adrenergic drug is go for alpha 2 receptor. Mirtazapine. Okay, and next group, Don family, trazodone, nifazodone, nifazo, and nifazo, and vilazodone, nifazodone. Okay, so these drugs they attach with 5-HT2, alpha 2, and alpha 1, and histamine 1. Okay, the side effect, important side effect, keep in mind priapism. But the most common side effect of SSRI, most common side effect of SSRI, most common side effect of SSRI in male, female both, decrease libido in male and female. That's an important thing. Okay. SSRI, SNRI, these drugs, when you're using antidepressant in patient, it takes longer time to give you benefit. Okay. They must explain to patient. You wait for 2 months before just their side effect little. Then the therapeutic effects they come later. Okay. It takes time. It takes time to reduce the symptoms of depression. Okay. Now, next we have been one family for mania and bipolar. Mania and bipolar disorder. So for this disorder, we're only having one drug, lithium. For mania and for bipolar disorder, we're only having one drug, lithium. Okay, lithium is known as mood stabilizer because in bipolar disorder, sometimes depression, sometimes mania. So it's your mood shifting, swinging mood, sometimes excited, sometimes depressive. So this drug is a real mood stabilizer. Mood stabilizer, okay? Lithium. So the question comes from lithium. The side effect of lithium very important. Okay? The side effect of lithium. Number one, in if the like in pregnancy, after if the baby die, the mother baby die during delivery or inside the uterus, that time mother mostly undergo depression. Yeah, and sometimes the mother having pregnancy, they having depressive is a natural thing. They having depression, thinking about more about baby and about his or her future. Still, baby is not in world, but still thinking. Yeah. So the mother in pregnancy having depression like this. So having sometimes depression, sometimes excitement. So you must avoid lithium in pregnancy. If you use in pregnancy, the pregnant lady taking lithium, it causes Epstein anomaly. Epstein anomaly. What is that? Epstein anomaly is tricuspid valve. Tricuspid valve. The heart issue, tricuspid valve. The one cusp is not formed. Like the problem with tricuspid valve. Okay, it's an Epstein anomaly. Must keep in mind. The second side effect: lithium not allow ADH to work properly. Diabetes insipidus. In diabetes insipidus. Okay, nephrogenic diabetes insipidus. It's work like anti-ADH, causing Nephrogenic diabetes insipidus. This person using lithium having polyuria, a lot of urine. Then again go for drinking, polydipsia, thirst, excessive thirst. Dipsia mean, this polydipsia mean excessive thirst. Okay, polyuria, polydipsia, again polydipsia. Why this happened? Because lithium not allow ADH to work. Okay, this ADH is not working on kidney. Understand? So lithium not allow ADH to work properly, so it lead to diabetes insipidus. Third side effect, it disturbs, lithium disturbs thyroid. Sometimes patient hypo, sometimes patient hyper. Hypothyroidism, sometimes T3 very high and very low and very high and very low like this. Okay, both hypothyroidism and hyperthyroidism. Understand? Hypothyroidism and hyperthyroidism, especially the big thing is hypo, mostly hypo. Lithium disturbs thyroid function. Number 4, it causing seizure. Lithium induced seizure, tremor. Okay, so in the patient, lithium induced seizure, tremors. So diabetes insipidus, abstain anomaly, hypohyperthyroidism, and seizure. These are the main side effects of lithium. For mania, we only have this hope. Lithium. For bipolar disorder, lithium is a drug of choice. Okay, must keep in mind. Lithium is a drug of choice. And what are the side effects? Abstain anomaly, diabetes insipidus, hypohyperthyroidism, and last one, seizure or tremors. Okay, so all about depression and mania done. This chapter is done. Okay, we're having 2 more chapters left. The CNS is very lengthy. I know CNS a bit quite boring as compared to ANS, but a lot of things is basic ideas and concepts come from ANS. Many things, the drug, how they're working, the side effect to understand very easy if you have very good grip on autonomic nervous system. Yeah. Okay, now we move on opioid system. Opioid. Opioids. So opioids, these are the for these drugs used for pain control. Okay, so these are analgesic. These are analgesics. They control for pain, not for mild pain, not for moderate pain, only for severe pain. Opioid we only use for severe pain. Okay, opioid we only use for severe pain. Understand? Not for mild, not for mild pain, not for moderate pain. Opioid. So opioid, how they working? So what are their groups? Okay, and what are they doing with our body? Opioids. Starting opioid. Before starting opioid, we must know some physiology. The analgesic system. In midbrain, we having periaqueductal gray matter. In medulla oblongata, we having raphe magnus. And in spinal cord, we having substantia gelatinosa. So neurons come from this to this part, then neuron moving to this part, then inside the spinal